As we get started, can you please put in a chat your child's favorite comfort item? Is it a support animal, a comfort blanket, or favorite stuffed animal? I'm Jill Brown, your sessions moderator for today, and I am a mom of an almost 12-year-old kidney transplant patient in which I was her donor almost 9 years ago. I'm also a member of Transplant Family's Board of Directors and the Executive Director of Northwest Kidney Kids, an organization serving kidney kids and their families. In this role as director of a nonprofit organization working with children through camps and mentoring programs, I became aware of trauma-informed model a few years ago and immediately knew our organization needed to shift and become aligned with the trauma-informed care. Since then, we have trained our own staff, volunteers, and counselors on understanding trauma and how we work with our population. I will let our presenter get into the details of this very important conversation. Today's session, PTSD and Pediatric Transplant, Integrating Trauma-Informed Care as Part of Your Care Plan. Today's contributors are both from University of Michigan. Dr. Melissa Cuzio serves as Director of Psychosocial Services and Research of the University of Michigan Heart Center. She leads the growing MCOPE program, which aims to increase access to mental health care, among other goals. Dr. Dussing is a pediatric psychologist, fellow of the University of Michigan Health at Mott Children's Hospital. She is focused on providing critical care to pediatric cardiological patients, and Dr. Dussing's research focuses on the impact of trauma on children and their families, which particularly emphasizes identifying ways to support children and family following trauma. Welcome, Dr. Dussing, to the conference.
Hi, Jill. Thank you for the introductions. I'm very happy and honored to be here. Like Jill said, I am a pediatric psychology fellow at the University of Michigan. And as part of my role, I work with cardiology patients to provide clinical care, mental health care. And I also work closely with Dr. Cuzino, who's one of our transplant psychologists. She is unfortunately not able to be here today, but she contributed to this presentation. I'm very grateful for her thoughts and her expertise. So we can go ahead and get started talking about PTSD and pediatric transplants and how we can integrate trauma-informed care as part of the care plan. So just a few disclosures from Dr. Cuzino. And before we dive into talking about trauma-informed care, just want to think about why are we here? Why are we even talking about trauma? So I think the answer to this is quite simple. We believe in the importance of caring for the whole child. So of course we want to care for kids medically. We want to make sure that they're physically healthy, but we also want to help kids thrive across every aspect of their life. We want them to do well emotionally, socially, at school, academically. And paying attention to all these different areas becomes even more important when we anticipate that there will be stressful events as part of a child's medical care. So with that in mind, we have a few objectives for today. First, I want to spend some time talking about just trauma in general, medical traumatic stress, and PTSD and pediatric transplant. I want to talk a little bit about trauma-informed care, why this is something that we even care about and how it could respond to trauma. And then thinking concretely, what does this look like in medical care? How might care change if we're using a trauma-informed approach? So a good place to start is just by getting our terms straight. We hear the word trauma a lot, and within the mental health literature, you'll even find subtle differences in what this might mean. What's similar across all of these, though, is the notion that trauma is a very serious event. It's something that threatens an individual's health or safety, and it can include things like abuse, neglect, or even a sudden or scary medical event. So we want to differentiate this trauma from something that's a stressor, something that's a stressful event. So stressors are going to be things that are more common. They're things that are hard to cope with, things that are, it's hard to manage that situation. It's very taxing. So for an adult, that might be something like losing your job. For a child, it might be something like missing a lot of school. And importantly, the experience of and the reaction to a stressful or traumatic event can look different across different people. So we want to be mindful of the subjective experience when we're thinking about how do we address this? How are we sensitive to trauma? So there have been decades of research looking at trauma and stress generally, just in the broader population. And some of the most well-known studies have looked at this concept called adverse childhood experiences, or ACEs. So ACEs look at a set of experiences, things like abuse, neglect, or difficulties at home, like parental incarceration or parental substance use. So all of these things happening before the age of 18. And what we've seen from recent studies of ACEs, like this one from the CDC, is that there's a rather high prevalence of trauma and stress just in the general population. So in this study that looked at thousands of adults across multiple states, about 61% of adults reporting experiencing at least one type of ACE before the age of 18, and about 16% reported experiencing 4 or more. So studies like these have really informed our understanding that trauma is important to pay attention to, especially just given this high prevalence that we see generally. So what these general studies don't necessarily capture is the unique experience of kids with chronic health conditions. But we know that kids with complex health needs are likely to experience stressful events as part of their illness and their treatment. And their illness and treatment can include potentially traumatic events. So when these occur, we expect there to be some period of adjustment, some period of distress for most kids. But for some kids, what we see is that these events can cause really significant distress or start to get in the way of things like school or relationships. So one way we understand children's reactions are through this concept called medical traumatic stress. So medical traumatic stress describes a response to an illness, an injury, or a medical procedure. It's not a disorder in and of itself, and it can look different across different people. So these symptoms or behaviors or thinking patterns that I've described here, these are ways that you might see this medical traumatic stress expressed by a child. So in the first category of intrusive thoughts, you might be seeing things like kids starting to have nightmares or bad dreams. Kids might have flashbacks where they're starting to re-experience some of that really stressful or traumatic event. For avoidance, you might see kids avoiding memories of the trauma, avoiding reminders. So for example, a child may not want to look at pictures of themselves in the hospital on their phone because it just reminds them of everything that happened. You might see changes in arousal or reactivity. So for some kids, that might look like being really irritable, being really cranky. Other kids might be really vigilant and kind of on guard, staying on the lookout for things that are potentially harmful. You can also see changes in sleeping patterns or difficulties paying attention, maybe at school, things like that. And then the last category looks at changes in the way kids think and changes in the way kids feel. So some kids may show difficulties remembering a stressful event. Other kids may show self-blame. They really feel like it's their fault for what happened. And other kids may become fearful or start to show really negative patterns of thinking, like feeling like just the world in general is a really scary, scary place. So when we're thinking about all of these different types of reactions to a traumatic event, we also want to be thinking about this through a developmental lens. So younger kids, older kids, they can show these symptoms or these reactions in different ways. So for younger kids, for example, you may see some of these intrusive thoughts present in play. So they're kind of reenacting their trauma that way. You can see things like temper tantrums or even like regressing developmentally. So they start to do things that maybe they had previously outgrown. So you might be sitting there feeling like, hold on, like, is any of this normal? What if I see my child doing some of these things? Does that mean that they have PTSD? And so, like I said, we do expect there to be some changes in emotions or behavior following a really big stressor or a potentially traumatic event. So sometimes you'll hear this described as like a normal reaction to an abnormal set of circumstances. Some of these normal, quote unquote, reactions that you might see would be, children are initially distressed, maybe after receiving a diagnosis, but it gets better over time. Maybe kids are really anxious with procedures, but they calm down relatively quickly. They can use some skills. They get through the procedure okay. Sometimes kids really don't like the hospital. That's also normal. Kids may also cry with bad news. Again, that's pretty much within the realm of what we would expect. So we want to differentiate those reactions from something that we would call PTSD, or post-traumatic stress disorder. So PTSD is a clinical disorder. It's a clinical level of concern that would develop following a traumatic event. And really, there's a whole constellation of symptoms present. So it's not just one or two of the things that we talked about previously, but it's a number of them that come together to show a more serious reaction to a traumatic event. So other things that differentiate PTSD is something that lasts for a while. So these symptoms aren't just present for a day, they're not just present for a week, but they last for at least a month in order to meet criteria for a diagnosis. These symptoms are also causing significant distress. They're really upsetting, and they're causing potentially impairment. So either distress or impairment. They're really getting in the way of what a child ought to be doing that's kind of like age appropriate. So family relationships, school, those types of things. One other thing that I want to say here too is that kids can fall somewhere in the middle. So kids can show some distress that's a little bit more than what we would expect for a typical reaction, but it's not quite falling in that PTSD category. So they can show any number in between. It's not an all or nothing thing. So there has been research looking at the prevalence of these post-traumatic stress symptoms, or PTSD, in pediatric transplants. And one study that looked at kids between the ages of 12 and 20 who were at least 1 year post-transplant found that about 14% of kids showed mild to moderate post-traumatic stress symptoms, so kind of that subclinical level. And then about 16% met full criteria for PTSD. So these have been associated with things like difficulties with adherence potentially, and then lower self-rated quality of life. So what I want to really highlight here, though, is that the majority of pediatric transplant recipients did not show clinically significant symptoms. Most kids did okay in terms of post-traumatic stress symptoms. So in addition to looking at kids, we also want to be thinking about what's the impact on caregivers, because we know that these experiences can affect the way that parents are thinking about things, having a lot of thoughts about what if my child gets sick again, thoughts about your child having to go back to the hospital, feeling scared or anxious or overwhelmed, or perhaps like avoiding things yourself because it reminds you of what's been happening. So one study found that about 27% of caregivers, and this is across organ groups, met criteria for post-traumatic stress disorder. And what the research has shown is that there's a relatively low association between parent and child post-traumatic stress symptoms. So a child may be reacting very strongly and show a lot of traumatic stress symptoms, whereas a parent is not showing that really high level, and vice versa. So it's not always a one-to-one. So I also wanted to highlight this visual model, which I think is really helpful in thinking about how post-traumatic stress symptoms may look over time. So this model comes from a review paper that was published in 2016, looking at medical traumatic stress. So I'm just highlighting part of the model here, and this is just a way for us to be thinking about what might we expect these symptoms to look like over time. So when a traumatic event would occur, we would expect these symptoms to increase, right? We would see some distress. For most kids, that's going to kind of level out and then decrease, and then they follow this like resilient pathway. For other kids, you see it increase maybe a little bit more, stay more stable, but then eventually, as that kind of acute period calms down, kids recover. They do better, go back to their baseline. And so as providers, one thing that we're really focused on is how can we help kids to be on one of those two trajectories, to keep those symptoms and that distress low, or if it's already high, how do we bring it back down? So what we want to avoid are one of these two pathways, where the symptoms stick around for a while or they continue to get worse. So that brings us to the idea of trauma-informed care. So trauma-informed care, we can kind of think about this as our response to the reality of trauma. It wasn't developed as a transplant-specific model, but it's certainly very applicable to kids who are going through their transplant journey. So what trauma-informed care also is not, it's not a specific trauma therapy, and it's not, a 5-session manual where we have a couple of checklists and, after a few weeks we say, great, we've done trauma-informed care, we can move on. So what trauma-informed care is instead, it's this really broad approach to care. And so we'll get in to some of the ideas about how we can see this play out. So to get into the mindset of trauma-informed care, we're going to start by talking about these 4 R's. So trauma-informed care realizes the impact of trauma, both trauma that may be occurring within a medical setting, but then also outside too. What other things are kids going through and how might that impact them? It also recognizes trauma symptoms when they occur. It responds to trauma by adjusting care to fit to the needs of a child. And then it also resists re-traumatization. So what can we do to prevent this from happening again for a child who's experienced trauma? In what ways may we need to modify care in order to make sure that we aren't constantly reminding of a child of something scary that they may have gone through previously? So within that mindset, we have these 6 principles of trauma-informed care that have been put forth to help guide our actions in our care. So a lot of these are self-explanatory and why they might be important for working with kids who have the potential to experience trauma. Things like promoting a sense of safety, promoting trust and transparency. And then some of the things that we want to do in addition to that are to promote peer support. So whether that's those people who are close to the child, continuing to engage them, or perhaps connecting kids to people who have similar experiences. We're also thinking about collaboration. So we don't want this to just be between the child and their doctor or the family and their doctor, but we want to involve everybody who's important, everybody who should play a role, and make sure that everybody's collaborating effectively. We want to empower kids and families. We want to give kids a voice and be able to say or have a say in what is going on. And then we also want to be responsive. We understand that people come from different backgrounds, have different experiences, and we want to be sensitive to that. So when we think about implementing trauma-informed care, we often think about, this happening in a hospital room or happening in an exam room between the patient and the provider, which certainly is part of trauma-informed care. But we're also thinking about multiple different levels. So how are we training our clinical staff to be sensitive to trauma? How do our screening procedures reflect, again, sensitivity to trauma and the language they use, the questions that they ask? How does our physical environment promote a more calming or relaxing environment versus something that's really scary or overwhelming? Thinking about how can we build partnerships with other settings outside of the medical setting. That's important for the child to really help the child thrive. And then even down to like our billing procedures and our institutional practices, how do these reflect the importance of assessing and treating trauma? So that's kind of our broad theoretical overview of trauma-informed care, which all sounds great. But you might be asking the question like, okay, what does this really look like on a very practical level? How does my child's care change as a result? So there have been, recommendations that have been put forth, and one practical framework that is useful for providers is the DEF framework, which focuses on distress, emotional support, and family. So again, this is a really practical framework for providers because we know that these different areas have the potential to impact how kids experience an event and then react to an event too. So if we're doing what we can to reduce distress, to provide emotional support, and to maximize family well-being, we're already hopefully avoiding potential traumatic events, but we're also putting kids in a position to do better if they do end up experiencing something that's quite frightening. So we'll go through each of these, and the first one that we'll focus on is distress. So with distress, again, one of the first things that we're thinking about is just the environment. What is the environment looking like? Is it immediately scary and overwhelming? And are there things that we can do to reduce the feelings of distress that might come from it? So maybe that's putting calming pictures on the wall. Maybe that's thinking about what a child might be hearing. Are there beeping or scary sounds that we can reduce? Or even like blinking lights? Is there something that we can do to manage that too? So making the environment as calming as possible. We're also thinking of ways to support a family's presence. So when a family is able to be present, that can certainly help kids to feel less distressed and more calm. There are probably times when that's not always possible, maybe if a child's going through a procedure. But thinking through as providers, what are things that we can do to support families to be present when that is possible? Another really important component of this is offering choices. So as part of the transplant process, there are so many things that are outside of a child's control, and that can feel overwhelming, that can feel scary. So we want to be thinking about what are things that we can do to put some sort of control, some sort of choice back into kids' hands. That might be things as small as like, do you want to take the red pill or the blue pill first? Do you want to be sitting or standing for this? Maybe in physical therapy, they get to choose between two exercises that both work the same muscle group, but they can choose which one they like better. So an important caveat to this is that we want to offer choices when they're possible. So we don't want to give kids a choice if there really is no choice to be had. Do you want to take your medicines? If that's something that they have to do, then we don't want to pose that as a choice where they could say no. Other things that we want to try to avoid would be threats. So sometimes when kids are really pushing back, maybe they're not wanting to take their meds or not wanting to participate in a certain care, we could say things like, if you don't do this, then this will happen, where the consequence is something that's kind of scary or frightening. And to a child who's experienced trauma, that can feel quite threatening or quite scary. And so we want to avoid doing that as much as possible where we're like threatening something that's scary. So choices are a good way to kind of give an alternative to that. Just giving, again, some sort of control back to a child. So another thing that we're focusing on is pain. So pain is certainly something that can contribute to distress and experiencing an event as really, really scary. So I want to give a shout out to our colleagues in Child Life who do a wonderful job thinking through pain management with our kids. And some of the things that they focus on are, how can we distract kids during a painful procedure? Distraction can be a really, really good tool for pain management. Or even positioning kids in such a way that's more comfortable during the procedure. And of course, our colleagues in medicine are always thinking about, are there medications or other ways that we pharmacologically can address kids' pain to help them feel more comfortable. So another way to reduce distress is by providing developmentally appropriate information. So when we have really hard, really heavy news or information to share with kids, we can feel kind of intimidated by that and tempted just not to share anything. What can happen with that is sometimes when kids don't have enough information, they start to fill in the blanks themselves, and the explanations that they come up with can be quite scary and perhaps even worse than what the reality is. And so being able to provide kids with information in a way that's appropriate for their age and for what they ought to understand can be really helpful. Another piece of this too is that we want to be thinking about the language that we use. In medicine, there's a lot of jargon. There's a lot of things that kids and even adults don't always understand. And so we want to be thinking about how can we change our language to make sure that there's less room for misunderstanding. So even something like a stretcher. If we say, okay, you're going to go onto a stretcher and then this is going to happen, kids might imagine being actually stretched out, their bodies being stretched out. They don't really know what a stretcher is always. So if we change our language to say something like you're going to go on a bed with wheels and then this is what's going to happen, it can feel a little bit more like, oh, okay, that's familiar. I can understand this new experience because you're using more familiar language. Or even things like a PICC line, kind of explaining it again in terms that kids understand. So, it's a flexible tube, things like that. So other ways to reduce this distress are by asking about worries. Again, sometimes we avoid talking to kids about things that could be worrisome or provoke anxiety because we don't want to trigger anything. But it is important to check in and just see how kids are doing. Ways that we can do that are just by asking open-ended questions, making broad statements like, I wonder if you're having any feelings about going back to the hospital. Or I wonder if you're feeling worried about the procedure that you're having tomorrow. Just kind of opening up that conversation for kids. And when kids respond, and if they do endorse some worries, of course it's in our nature. We want to be able to provide reassurance and say, it's okay, you don't need to worry. Sometimes that can feel a little bit dismissive. So one thing that we can do when kids express their worries is to really validate, say yeah, I understand why you might be feeling that way. And then help kids to problem solve too. So those are some ways that we can help to manage distress. And now we'll jump into thinking about emotional support. So thinking back to those 4 R's in trauma-informed care, one of the very first things that we want to do is recognize when kids are struggling. In order to be able to effectively provide support, we need to know when things aren't going really well. And I think this is one area where parents, you are so uniquely positioned to recognize this because you are the expert on your child, you know your child. And even if a child's telling a provider, I'm fine, I'm not worried, I'm doing okay, you notice when your child is struggling. And so keeping an eye on how kids are doing and then partnering with your child's team and sharing that information when it's appropriate to help people know when we may need to be especially sensitive to how a child's doing. So other things that we can do are strengthen kids' coping skills. We want them to be able to manage difficult and stressful situations well. One kind of image that I use in my own clinical care is this image of a coping toolbox. So just like you wouldn't have a toolbox that only has a hammer, we don't want to have our coping toolbox with only one skill. So a hammer is useful in a lot of situations, but not in every situation. Sometimes you need a different tool. And so when we put together our coping toolbox, we want this whole repertoire of skills. We want to be able to adjust our coping strategies according to the demands of a situation. So maybe distraction is really helpful in one situation, but another time it's helpful to talk to somebody. And just thinking through with kids, what might those look like? And then also thinking ahead. When we anticipate that there will be a stressful event, we don't want to, just put kids in a situation, see that they're stressed, and say, like, okay, now use deep breathing, without ever having practiced before. That's like talking to a basketball player, putting him in a game and asking him to make the game-winning shot without having done any practices. We want to be thinking ahead. And with transplant, there are so many times where kids may be put in a stressful situation. And so when we can identify those ahead of time and think through strategies, so for example, like getting a call that an organ is available and you need to come to the hospital, that can be a stressful or certainly an unfamiliar experience for children. And so thinking through when that happens, how do you want to handle it? What are some things that you want to do? Maybe you want to listen to certain music. Maybe you want to call someone or play this game on the way to the hospital. That way, when kids are put in that situation, they kind of have an idea of what they're going to do. They're not caught totally off guard with how to cope. So we also want to enlist social supports, whether that's hospital resources. And the resources are going to vary by hospital, but there are so many to draw on: social work, psychology, psychiatry, art therapy, music therapy, so many that we can get involved to help support kids. And then also thinking about outside the hospital. Who are the friends, who are the family, who are the community members who we can get involved to support kids? And then the last piece is that we want to consider referrals when needed. So as providers, part of this is for us to be familiar with what resources are available and to be comfortable talking to families about if this is something that would be helpful. So the last piece here that we'll talk about is family. So just like for kids, we want to be able to identify what kids need. We want to be able to identify what families need. So our colleagues in social work are frequently very involved in helping identify both emotional needs of families and then also practical needs. And things that we can do are certainly to check in with caregivers. How are you doing? How are you feeling? Is there anything that we can do to support you? But then also thinking about siblings. It can be hard to have a sibling who's at the hospital. And so finding ways to connect family members can be so helpful. And with COVID over the last couple of years, it's not been easy, but finding those creative ways to keep siblings connected. So certainly FaceTime, texting, calling, those are great options. Other things that could be useful would be like requesting the same project from Child Life, having one child at the hospital, one child at home doing the same things, and then sharing their work with each other. Maybe they like the same TV show and they can watch that at night and then share their thoughts together the next day. Lots of different ways that can depend on siblings' interests. And so we don't want to just be thinking about where families may be struggling or where there may be needs, but we also want to be thinking about family strengths and resources. So what are those things that a family really has going for them? Maybe you're really patient with your kids, and that's something that we can build on to help everyone do better. Maybe you have a really supportive clergy member or parish community that you can draw on when things are getting really tough. So, we've focused a lot on providers so far, but we also want to be thinking about what are some things that parents can do that would be consistent with trauma-informed care. So in addition to focusing on how your child is doing and just keeping tabs on that, we often encourage parents just to check in with yourself. How are you doing with everything that is going on? And it can feel kind of unnatural, it can feel even selfish to spend that time focusing on how you're doing. But what we know is that when parents do well, kids tend to do better. So taking that time to make sure that you're doing okay is a really, really good way to help your child. So ways you can do that, just taking a step back, taking 5 minutes. If you've been on call for your child, all night, or you've been at the bedside for a while, just taking a few minutes to yourself to recharge and come back. Other things would be, remembering the basics. When we are in the midst of a very stressful experience, things like sleep, things like eating, things like brushing your teeth, that can kind of fall by the wayside. So remembering to incorporate those regular activities just to keep on top of taking care of yourself is very important. Other things, you want to keep tabs on how you're feeling and your own reactions to events. So if you know that you tend to maybe get really anxious when your child is getting a dressing change or when they are getting an IV placed, monitoring how you're doing. Is your voice level and calm? It's not loud or raised. Right? If you're tearful, knowing that it's okay to step outside the room for a second. The reason why this is important is that kids look to parents to see how you're reacting to an event to really inform themselves of, okay, is this safe or is this scary? And if they notice that parents are feeling really anxious, that can tend to raise anxiety for children too. And so it really is okay if you feel like you need to take a step back. It's okay to do that. Let nursing or child life support your child for a few minutes and then come back and let your child see you calm. So the other few things here are just asking for help when you need it. This is completely new territory for many families. Most families don't enter this process with a wealth of experience in pediatric transplant. So knowing that it's okay to ask for help, whether that's from a friend or even for professional support. Things to think about when you're wondering if, hey, would I benefit from professional support? Asking yourself or monitoring like how you're doing, those reactions that you're having, that's an important indicator. And then realizing like, is this starting to get in the way of things? Just like how we asked for a child, is it starting to get in the way of things? Asking that for yourself and seeing if that would be a useful resource for you. So the last couple things are just thinking about routines, sticking with those daily routines as much as possible, and then continuing to cultivate really good and supportive relationships with people who are important to you. So I'll end by saying just that trauma-informed care is not a one-man show. There are many people on the team, many people who can get involved with this approach. And everybody has their own role, but they also have a shared goal. Our goal is really to support the child. So as parents, one thing that you can do to continue to promote trauma-informed care in your child's care plan is just by starting this conversation with your care team. And you can do this proactively just by asking, what resources are available for my child? How do I access them if I feel like I need them? And when you have concerns, talking to a trusted member of your child's care team, starting off the conversation like, hey, I've noticed that this is really hard for my child. Do you have any suggestions or recommendations? And offering some of your own too, knowing that what's possible might depend on the specific situation. But again, just starting that conversation, building that partnership is really a tremendous way to support your child over the course of this process. So I'll end by sharing some of these resources. These are some of my personal favorites, some of Dr. Kuzno's personal favorites, resources looking at trauma-informed care, trauma generally, and then also pain, and then child well-being or caregiver well-being too. So I would invite you to take a picture, look them up at your leisure, especially if you're interested in getting more information. So with that, I'm happy to answer any questions, provide some additional information. So of course, I won't be able to provide clinical advice for specific situations or questions that you may have about your child. And I would always encourage just to talk to your child's care team if you have specific questions or concerns. But I'm happy to answer any questions and provide some information.
Thank you. We look like we do have a few questions. Before we get to that, if you guys have other questions, please put them in the chat and we can get them answered. We have a little bit of time, so it's definitely time for Q&A today. But we do have a trivia question, so you can win a door prize, and it's what percentage of adults that experience some type of trauma during care? So you put the answer in the chat, and if you win or you get the closest, you'll win the door prize. So let's get started with the first question, which is, what are some strategies for recognizing and dealing with the signs of trauma in kids who are unable to articulate their feelings due to the age or developmental issues?
Yeah, that's a good question. And I think, this is a time where you can really think about, your child as a parent, when their behavior looks a little bit different from what's typical. So like I said, for younger kids, you may see like tantrums. And so when we know that kids have experienced something that's stressful, and we start seeing some more behavior problems, that might be one sign of like, hey, they're struggling. You may also see, tearfulness. Kids may not always be able to articulate what's going on. And so just keeping an eye on if you're seeing any of those changes from their baseline can be a really useful strategy for recognizing it. And then you asked about kind of dealing with some of those signs of trauma too. I think for this, it would depend on exactly what it looks like. And that might be a good time to talk to a member of your child's care team just to say like, hey, I'm seeing this. What can we do to help support my child? Because I think that this means that they're struggling.
That makes sense. The other question we have is, can you use labs as an example of how to talk about trauma-informed care? Often lab techs are rushed, and I think we all agree that our kids remember this as trauma for most. It's funny, we had this conversation before, and I had the opposite reaction or the opposite thing with my daughter, but I think that this is a good one since all of our kids have so many labs to monitor their transplants.
Yeah, no, it is such a good question and something that comes up frequently. So I think the first thing is just thinking about it ahead of time. What can be helpful? Coming up with a plan. Are there certain things that might distract your child during this procedure? Are there certain ways you could hold them or position them? And then when you show up to get the labs, talking to the tech, before they immediately try to get labs from your child, just say, hey, this might be hard. Is it okay if we try this? And trying to really integrate maybe the plan that you came up with your child and getting that provider involved. I think those are good strategies to try right off the bat.
This wasn't a question, but I thought it was a great comment, and there's been some responses to this in the chat. Was someone said, I think it was actually Mackenzie, and she said, I was 16 when I was diagnosed, but my mom would always stress out, and I had to be the strong one. I had to calm her down. That wasn't healthy. And I was thinking about this question is like, we do probably have some young adults or transplant patients who are watching that may have the same experience, or sometimes as parents retroactively we're like, ooh, we do that. So what are some things that as a patient or a teenager going through this could maybe do to help that response, or as an adult, if we recognize that maybe this is our response, what could we do in addition or changes?
Yeah, so I'll start with the adults. What can we do? And I think monitoring our reaction and having that self-knowledge is a good place to start. When we notice that we're feeling a little bit out of sorts and we see that it's affecting our child, or we have an idea like, hey, this might start to get in the way, taking that step back. I think talking to a trusted member of the care team is a good idea from the standpoint of they have lots of experience too. If they've seen this kind of dynamic come up, what have they seen work for other people in the past? And they know you and your child well, and may be able to provide some guidance in a specific situation. For a child, if you feel like something that, a parent is doing that's not really helping the situation, I think, you know, uh, talking about that in a way that's like not like blaming is usually in my own clinical experience where we start. And that can be if, as a child, you're talking about it, or, you ask another member of the care team to say something. Just talking about it in a way that's saying, hey, when this happens, I feel this way. And so really putting the focus on like your own experience of it, rather than saying like, when you do this, like everything goes poorly, and putting the blame, because that can lead people to feel defensive. So in my own clinical practice, that's usually where we start.
And I know just from my experience as a transplant parent is when you find yourself in those situations with your kiddo in the hospital or needing to do a procedure and they really are no, there's no choice. What are other things we can do as a parent? You said, physical distance or being close to them helps, but, is there things
Mhm.
that we should be like bringing up to the medical team or, talking to the nurses about before those procedures or like to be more proactive about that? Or
Mhm.
is it just something that you're going to have to just hold them down and let them go through it?
Yeah, um, it is a good question. It is hard. I think so. First of all, being proactive is usually a good thing. And so saying, hey, I anticipate that this is going to be stressful for my child. I'd love to give them a choice, but I know that's not an option. So some of the things that, um, maybe helpful would be like giving your child, if not a choice, some sort of say. So, you have to do this maybe in the next 10 minutes. Do you want to do this in 5 minutes, or do you want to do it in 10 minutes? Or do you want to do it now? And so just giving them some sort of control over the situation. And then maybe like gradually um, building up their ability to manage certain situations. So maybe trying one coping skill, evaluating, did that work? Did it not? What can we do next time? And again, building that partnership with your child too, to say, um, what could we do next time to make this a better experience? I think is a good way to try that as well.
It reminds me when we were at the vaccine clinic and the nurse, there was a girl who was, in her teens and she was obviously really afraid of the vaccine, as some kids are, and getting a shot. And I thought the nurse did a really good job because she gave her choices. Do you want to be a part of this? Do you want to look at me? Do you want to look away? Do you want me to tell you, or do you want me to count down? Or do you want me not to tell you and just surprise you? Do you want the
Mm-hmm.
left or right arm? So she gave her so many choices that it just seemed like that's exactly the way that it all should be, right? So maybe if it's like I get that veins aren't always easy to draw from, but maybe letting the kids choose which arm they try first or things like that could be helpful in those choices. But thinking about where those choices could be that they can make.
Mm-hmm.
What can parents do to comfort each other during times like this? In our case, my spouse was postpartum at the time of listing and transplant. Of course, there are many asymptomatic uh, situations. Yeah.
Yeah. Um, it that's another so many good questions. Um, so I think first of all, just being in tune to what each other needs in this time. Some adults like to talk about things. Some adults don't. Um, and realizing that you may be at different stages of kind of processing this experience. Um, And so I think first and foremost, just understanding where each other's at can go a long way. Um, and then talking to each other about like what would be helpful too. Is it helpful for you to take a break? Is it helpful for you to be here? Um, and continuing to like look out for ways that you can help the other person. Um, it it can be so meaningful just to have those like little things that you can do that your spouse or your partner can see and notice, like, hey, someone's looking out for me, and that in and of itself is quite comforting.
Great. It doesn't look like we have any other questions. And just FYI, no one's gotten the trivia question yet. What percentage of adults have some type of traumatic experience? So if you still want to guess, you're welcome to do that. Thank you so much for your time and your presentation. Such an important topic today. Do you have any, I think the other request was to put back up your slide maybe so that they can get those resources again. I think some people still need it a little bit.
Yeah.
And I'm going to remove myself so that they can, I don't have to remove myself. So maybe just go back. Yeah.
Can you see it okay?
Yeah.
Okay, cool.
So we'll just leave that up for a second or so. Any closing thoughts or comments? All right. Well, thank you for your time.
Thank you for having me here. I really appreciate the opportunity to share this with everyone, and loved hearing your questions. And I'm grateful for this opportunity.
Well, thank you. Have a good day.
So.